tell me this now. A patient comes to you. What is the primary treatment for these cancers? What is the patient comes to you with advanced? I'm saying nodal or advanced. What is the primary treatment? You said something about radiation. What is the primary treatment that you use for this cancer?
So this has really evolved over time.
Or let me say 6 months back, what would you use?
So 6 months back, so again, and I'm biased, obviously we're a clinical center, so we had access to clinical trials, but talking very generally, when patients present, this is still primarily a surgical disease, at least in the onset, even with patients who have node-positive disease. As long as a good multidisciplinary team can evaluate that patient who has palpable nodes, so macroscopic nodes as we would describe them as, and determine their eligibility or non-eligibility for surgery, I think that's where we first sort of the fork on the road. If they are eligible for surgery and staging, typically CT imaging demonstrates no evidence of distant metastatic disease beyond the confines of the surgical basins, then typically those patients, as long as the surgery is not considered to be unusually morbid or cosmetically disfiguring, particularly on the head and neck area. We see a lot of patients with scalp CSCCs, again, primarily related to sun exposure. As long as the surgery can be adequately performed with negative margins, with good recovery, that tends to be our first treatment of choice. In selected patients, particularly those that are considered high risk for recurrence, and again, a variety of criteria to define that from a nodal perspective, the size of the nodes, the number of the nodes, and the presence or absence of a characteristic called extracapsular extension. The presence of ECE or extracapsular extension puts these patients at a higher risk for regional recurrence. We would consider those patients for adjuvant radiotherapy. The key question,
radiation after all has been
the radiation after the surgery to reduce their risk of local regional recurrence. The key question in that was recently answered was, does the addition of chemotherapy to radiation improve the odds of cure or reduce the risk of regional relapse? The TROG, which is the Trans-Tasmanian Radiation Oncology Group, conducted a very well-designed randomized trial recently that was reported earlier this year, where they randomized patients with high-risk cutaneous squamous cell carcinoma and nodal involvement to receiving postoperative radiation versus postoperative radiation standard dosing plus weekly carboplatin. And essentially what they found was there was no benefit to the addition of chemotherapy. Some caveats there, however, that these are patients that even in the control arm actually did better than anticipated. So the question is, can we still further truly dissect down that data to identify who is truly at even a higher risk that may warrant chemotherapy in addition to radiation? We're still trying to understand.
Well, right now, the standard of care would be radiation
Postoperative
after
radiation.
in this higher kind of high risk patients, and everything would postoperative radiation. Now, suppose somebody had presented with a lesion which is non-surgically resectable. Sure. What would be the first treatment be?
So there are again a variety of options, and traditionally for those patients we would have either considered definitive radiotherapy by itself, a combination of chemotherapy plus radiotherapy, and now more recently, based on data and our better understanding of the biology of this disease, definitely consider immunotherapy for them. And this is immunotherapy targeting the PD-1, or programmed death receptor 1 pathway. We now actually have a drug that's the first of its kind to be approved in CSCC, which is cemiplimab, which is a human antibody against the programmed death receptor 1, just received approval a couple of months ago, based on some very good, albeit early data, but very good data that we actually participated in that clinical trial as well. So I think the options have certainly expanded. One of the caveats to recognize is these patients that present, because this is a disease that tends to increase in incidence with age, these are patients that may have associated comorbidities. They may have renal failure or at least a decline in their GFR. So it's harder to get in drugs such as platinum, which tend to be used more commonly.
Like cisplatin and everything, these drugs which can cause, this can cause issues.
Nephrotoxicity, correct. So it's a little bit harder to get those drugs into these patients. The traditional drugs that we used would be platinum agents, taxanes, including paclitaxel, 5-fluorouracil, very similar to what we would do with head and neck mucosal squamous cell carcinoma. And then we also have drugs that are targeting the epidermal growth factor receptor pathway, EGFR, typically cetuximab or panitumumab. Again, these responses to chemotherapy tend to be modest, or even to targeted therapy tend to be modest. We see a small percentage of patients developing complete responses as well. but the duration of response tends not to be as durable.
So when you do the therapy, chemotherapy, or it can control it for some time, but it's not durable, and that's where newer therapies are coming into play, newer clinical trials, and newer approvals coming into play.
Exactly.
We'll talk more about that in our next segment.